All right. Good evening, everyone, once again, and welcome to the March edition of the K-Health Speaker Series, which will be our last for the 2020-2021 school year. We're so excited to have you here this evening. I'm Brittany, and I'm one of the ICHP coordinators this year, alongside Peter and Nishita. For those of you who may not know, the ICHP is an interprofessional program that focuses on developing skills to better serve vulnerable populations. And we do this by offering different educational components for participants to complete. These speaker series are one of those many components, and completing a certain amount of those components allows participants to receive a certificate at the end of the year. This year, we set up a mini version of the ICHP and received a lot of interest, which is great. For next year, we're hoping to further develop the ICHP into a full-fledged program with even more components, such as training workshops and group case competitions, to allow students to further personalize their learning experience. ICHP participants, please continue to document your completion of the components. The components must be completed and submitted to the ICHP email address by May 15th at 11:59 p.m. And that email address, I'll be sure to send it into the chat box in case anyone needs it. At the end of the talk, we will also post a Google form. So if you have a chance, please fill it out and provide us with some feedback. All right, so without further ado, I have the utmost pleasure of introducing our speaker tonight, Kelsey Morrison. Kelsey is a clinical psychology PhD candidate from the University of Saskatchewan. She works with individuals with developmental disabilities across the lifespan at Queen's Developmental Disabilities Consulting Program. Her research interests include chronic pain, attachment theory, harm reduction, and psychedelic assisted therapies. I'll hand it off to you now, Kelsey. Thank you so much for joining us today.
Thank you so much, Brittany, for the lovely introduction and for having me here today. So my talk is entitled Dual Diagnosis, Supporting the Mental Health Needs of Individuals with Developmental Disabilities. Let's see. So before I get started, because I'm sharing my screen, I just wanted to ensure, should I minimize the people on the side, or can you see that? Is it blocking the slides? Nope, all good, excellent. Okay, so just a little disclaimer before getting started. So the one takeaway that I'm hoping to give to you today is that the mental health needs of a person with a developmental disability are fundamentally the same as for all human beings. And also, I guess a second disclaimer, I have two pets with me here, a cat that likes to wander across the screen, as well as a brand new puppy. And he's napping right now, but I apologize if he gets vocal at any point in time. Further, just some housekeeping about language. I try to stick to the same term throughout the presentation, which is developmental disability. I abbreviate that at times to DD, not to be confused with dual diagnosis, which I'm also talking about. If you're looking at any literature, some phrases that are used interchangeably at times are neurodevelopmental disorder, intellectual disability, or learning disability. And in particular, if you're looking at any research coming out of the UK, you're likely to see it as learning disability rather than any of the other three. So just to provide a brief outline of what I'm going to be talking about today, I'm going to discuss neurodevelopmental disorders as defined by the DSM-5. And I'm going to specifically look at diagnostic criteria for intellectual disability and autism spectrum disorder, which are two diagnoses that I have a lot of experience working with. I'll discuss dual diagnosis and special considerations regarding this matter. I'll move into assessment and diagnosis of mental health conditions in individuals with developmental disabilities and special considerations and limitations in this process. And then I will discuss challenging behaviors, guidelines for working with them, and the functions of challenging behaviors. And then I will talk about some interventions, barriers to accessing intervention, and modifications we can make when providing these services to individuals. And then briefly, just to tie it together with my impression of what K-Health does, I have a little bit on interprofessional teams. And then I'll leave some time at the end for discussion. However, if anyone has a question throughout, please feel free to interrupt and ask away. The DSM-5 neurodevelopmental chapter defines neurodevelopmental disorders as a group of conditions with onset in the developmental period. So this is the early childhood years. We usually see this either before or around the time that a child is entering school. They're characterized by deficits that produce impairments of personal, social, academic, or occupational functioning. And like I've already said in the overview, I am going to focus specifically on intellectual disability and autism spectrum disorder today. And just for some stats, in Canada, estimates of percentage of children with a developmental disability have ranged from 6.5% to 8.3%. When you break this down into looking at specific diagnoses, it's about approximately 1% of the general population that we see with an intellectual disability and another approximate 1% for autism spectrum disorder. So before we jump into diagnoses, it's helpful to consider development across the lifespan when looking at these disorders. So there are various stages of cognitive development and psychosocial and emotional development that we go through as human beings. In the early stages of cognitive development, our mental processes are very action-oriented and rooted in concrete operations. And over time, these become evolved in more complex mental operations. So we sort of move from thinking more concretely to more abstractly. And in terms of psychosocial development, we move through various stages of mastering increasingly complex attitudes, ideas, and skills. So individuals with neurodevelopmental disorders pass through stages similar to neurotypical individuals. However, this may occur at a slower pace, and they may not reach the same endpoint as their same age counterparts. And I think just having this kind of understanding of development in stages and that an individual may kind of be stuck in a certain stage is really helpful when we're working with individuals with disabilities. So an intellectual disability is characterized by deficits in intellectual functions that are confirmed by both clinical assessment and individualized standardized intelligence testing. And it also is characterized by deficits in adaptive functioning that result in a failure to meet developmental and sociocultural standards for personal independence and social responsibility. And the third criterion for meeting the diagnosis is that onset of these deficits occur in the developmental period. And when we're making a diagnosis of intellectual disability, we always specify the level of severity. So that can be mild, moderate, severe, or profound. In the past, we used to classify severity based on someone's IQ score. And a lot of individuals still believe that we do it this way. However, it has recently changed, and I believe as of DSM-5. So severity is now specified based on an individual's adaptive functioning, and this was done because it's an individual's adaptive skills that dictate the level of support that they're going to require. So next, autism spectrum disorder is characterized by persistent deficits in social communication and social interaction across multiple contexts. This includes deficits in social emotional reciprocity, deficits in nonverbal communicative behaviors used for social interaction. This can include things such as the use of gestures or maintaining eye contact, as well as deficits in developing, maintaining, and understanding relationships. The severity is classified as level 1, level 2, or level 3, and this is just trying to capture the level of support that an individual needs. Criterion B is that there are restricted repetitive patterns of behavior, interests, or activities as manifested by at least 2 of the following. So there could be stereotyped or repetitive motor movements, use of objects or speech, So this could be simple motor stereotypy, such as hand flapping or lining up toys or echolalia. There's insistence on sameness and flexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. So this could look like experiencing extreme distress when a routine is changed slightly, or requesting to eat the same food every day and refusing to eat anything else. It can have highly restricted, fixated interests that are abnormal in intensity or focus. So with a lot of my clients, I have become very well versed in talking about things such as comic book characters and Pokemon and Minecraft, lots of video games and television characters, as well as hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. This can look like an indifference to pain or temperature, excessive smelling or touching of things, or having a visual fascination with flashing lights or spinning objects. Criterion C is that the symptoms must be present in the early developmental period, but these symptoms may not become fully manifest until the social demands that the individual is under exceeds their limited capacity, or they may be masked by learned strategies later in life. This is really interesting for the diagnosis of autism in females. So in females, autism can sometimes go missed or undiagnosed until they're much older. And it seems that females in particular are better at sort of mimicking facial expressions and learning sort of social rules. So they can sort of talk the talk, but not necessarily understand why they're doing it. Criterion D is that the symptoms cause clinically significant impairment in various areas of functioning. And finally, that these disturbances are not better explained by intellectual disability or global developmental delay. However, intellectual disability and autism frequently co-occur together. And then we also have specifiers we attach to the diagnosis. This just provides clinicians with some additional information about the individual. So it can be with or without intellectual impairment, language impairment, due to a known medical or genetic condition or environmental factor, or that it's associated with another neurodevelopmental, mental, or behavioral disorder, or with catatonia. So the term dual diagnosis is used to describe a situation in which someone has a developmental disability and a mental health diagnosis. People who have developmental disabilities can have any of the same physical, psychiatric, or emotional difficulties as any other person. And they're actually 3 to 6 times more likely to have a mental health problem, which is substantial. Often these disturbances are first recognized by others because of changes in the person's behavior. And this can be due to communication limitations. So they may have difficulty verbally sharing their inner experiences. And this change in behavior is a means of communicating that something is wrong. So there are some issues when working with individuals with a developmental disability that are important to be mindful of. The first being that these individuals are extremely prone to being abused and exploited. In terms of sexual assault, this is a very high risk group, and perpetrators of sexual assault against these individuals are most often not strangers, and typically include family members, friends and acquaintances, and alarmingly also service providers. So when I'm working with someone with a disability, I always take a trauma-informed approach. So even if I've looked at their file ahead of time and I don't see any indications of trauma on file, I still make the assumption that they've probably experienced some form of abuse or neglect or trauma in their past. There's also the phenomenon of the cloak of competence, which occurs when a person with a disability, because of some relatively good skills, gives the impression of greater understanding and functioning than they actually have. I see this a lot when I'm consulting with professionals, and I might have an assessment that says the individual has a moderate intellectual disability, and the professional is coming back saying, "Oh no, I think they're in the mild range." But it's often the case that they are able to use language at a level that is higher than their ability to understand language. Another issue is diagnostic overshadowing. So this is something that happens when any changes in behavior or unusual behavior are attributed entirely to the individual's disability without considering that there could be a psychiatric issue also occurring. And there are various biological, psychological, social, and familial factors that lead to increased vulnerability to developing a mental health problem. I won't go into great detail here for time purposes, but for example, in terms of biology, there are behavioral phenotypes that can cause certain conditions. So individuals with Down syndrome are actually more likely to develop dementia and more likely to develop this at an earlier age than a neurotypical individual. And then there's also the issues that these individuals often are met with negative attitudes from individuals. They have low levels of social support, poorly developed social skills in some cases, and they may have a family history of psychiatric or emotional problems as well. So mental health problems are often first recognized by others rather than the individual presenting it themselves, and this is due to changes in their behavior. Um, so behavior is communicating something important to us. It is telling us that something has happened, that there are unmet wants or needs, or some sort of internal experience that they're trying to cope with. So the primary goal of our assessment process is to understand what the changes in behavior are communicating for that individual. One of my big roles is psychological assessment. This includes standardized assessment measures where we look at an individual's cognitive functioning, academic achievement, psychosocial functioning, and adaptive behavior. I also will conduct a clinical interview. I will, when I can, try to interview the client themselves. And sometimes they can be a part of this and sometimes they're not able to, depending on their verbal abilities. I also like to have multiple informants. So people that know the individual very well, parents, care providers, teachers, and so on. I want to get a good developmental history. So I want to know what mom's pregnancy was like with the individual. Did they meet their developmental milestones on time? What were their early school years like, and so on. And I also am interested in knowing any services or interventions they've received in the past. So when I'm doing an assessment, I'm really interested in, if it's an initial assessment, I'm interested in establishing a baseline of their current functioning. And then at any reassessment, I'm looking at capturing any kind of change from baseline. This is relevant across the lifespan. So if I'm assessing a child, I want to establish a baseline. We often give provisional diagnoses because they're still growing and developing. And then in a few years, we can then reassess and see if things have changed. And then working at the other end of the lifespan with seniors, if we have a good baseline of functioning, we can look at if there has been cognitive decline when we're making diagnoses such as dementia. And when I'm doing an interview, I'm always looking for the frequency, onset, and duration of symptoms. This is to help make distinctions between whether or not people are meeting diagnostic criteria. And then sometimes, not always, but it's nice when we can. COVID has limited this a little bit. But we also like to do observation where we go into the home, school, or work environment and observe how the individual is functioning there. So there are limitations encountered during the assessment process. The clinical presentation of psychiatric disorders is often different in individuals with disabilities compared to a non-disabled population. This is especially true in the more severe range of disability. Diagnostic criteria are weighted toward verbal items and intellectually complex concepts. So sometimes we're asking an individual to do things that they don't really have the template for. I kind of think of this as giving someone the materials and asking them to build a house, except they don't have the blueprint. If you are interviewing or assessing the individual without an informant, even if they're relatively high functioning, they can still have trouble remembering the sequence of events and the timelines of things. These populations are also prone to acquiescence or a tendency to just say yes and to be agreeable. Sometimes we'll try to provide multiple options rather than a yes or no question, but then you also run into the issue that they'll often just provide the last choice or say the last word that you said. And there are also limitations to interviewing informants. So sometimes background information is not available. This is especially common in adoptive families. It's also dependent on the observation and experience of the caregiver. And some people are very good at this and others are not. There's also personal bias. So a lot of the times when someone comes into an assessment, a caregiver will already have the diagnosis that they want in mind or what they think is the case. And they aren't always agreeable if we come back with something different. This can be just because this is how they understand the individual. And it can also be because certain diagnoses lead to different supports and services that they're eligible for. Now I'm going to look at a couple of different psychiatric diagnoses, starting with psychotic disorders. So these are characterized by hallucinations, delusions, disorganized incoherent speech, or grossly disorganized or catatonic behavior. Psychotic disorders occur more frequently in adults with developmental disabilities than in other adults. And this is despite difficulty presented by limited verbal communication skills. And it's also likely that a proportion of these disorders go undetected. I don't specifically talk about medication in this presentation. I think that is better suited for psychiatry. However, antipsychotic medications are also very frequently prescribed in this population, not always for psychosis, but there are a lot of off-label uses for managing challenging behavior. So sometimes there can be a difference in the quality of psychotic symptoms from psychotic symptoms experienced by a neurotypical individual. So a typically functioning individual may firmly believe their delusional beliefs and you cannot convince them otherwise. But a person with a developmental disability may be able to sort of be talked out of a delusional belief. One way to kind of clarify this is to observe whether the person repeatedly states the false belief after you've talked them out of it. And this can happen voluntarily or if you ask them. And it's also important to note that the content of the delusions and hallucinations are often developmentally appropriate for the person's overall ability level. So if I was working with someone that was 30 years old, but they function at the level of a 5-year-old, their delusions may involve something like ghosts or monsters under the bed, which would seem kind of inappropriate for someone their age, but not when you consider their developmental level. In terms of mood and anxiety disorders, they often go unrecognized due to communication difficulties, especially in describing internalizing symptoms. So this is like things like feeling low self-worth or experiencing a lot of rumination. There's atypical presentation of symptoms, so it's hard to see whether or not they meet diagnostic criteria. And often symptoms are masked by challenging behaviors. There are various triggers to mood and anxiety disorders. Some include changes to routine, moving homes if they're in a group home, illness or chronic pain, experiencing abuse, crime, or other trauma, bereavement, and usual support staff leaving. So sometimes we see that individuals get really attached to certain people that they work with, and if they switch jobs or go elsewhere, we can see that they have a really hard time adjusting with this. So symptoms of depression actually look very similar to what they do in the general population. It's just that we have to know the individual to see if these are changes based on, compared to their usual level of functioning. So depressed mood can look like a loss of energy, a loss of confidence, being very tearful all the time, an increase in physical symptoms, an increase or decrease in motor activity, reduced concentration or increased distractibility or indecisiveness, and an increase or decrease in appetite or increases or decreases in sleep. And so with anxiety, this can look like sensory defensiveness, communication impairments, social skills or peer rejection changes, difficulty tolerating uncertainty, difficulty with change and transitions, and rigid thought patterns. So this may sound familiar because there is a lot of symptom overlap between both autism and intellectual disability and anxiety. So to clarify between these two, it's important to know what the symptoms of the disability are, and then on top of that are the symptoms being expressed, exacerbated or a change from what is typical for their disability. Challenging behaviors are a very big topic in the field, and probably one of the most common reasons for referral for individuals that I see. Challenging behaviors are behaviors that are of significant frequency, severity, or chronicity as to require clinical assessment or special intervention. They result in a significant negative impact on quality of life and or safety of the individual or others that are around the individual. And they can lead to negative attitudes from caregivers and lead to caregiver burnout. So challenging behavior typically serves a purpose for the individual. It can produce sensory stimulation, it can provide attention, it can lead to avoiding demands, and it's a way of communicating. The prevalence of challenging behaviors are around 5 to 15% in various settings. And the rates are higher in teenagers and in people in their early 20s, and also in particular settings. So we see rates of 30 to 40% in hospital and treatment home settings. And also some care environments can increase the likelihood of behavior that challenges. So if an individual is in an environment where they're not getting enough attention, or there's neglect involved, or excessive noise due to other housemates, we can see increases in behavior. So it's always important to assess and understand what the function of the behavior is. That really helps clarify the diagnosis piece. So behavior is strengthened by either getting something or getting out of something. And there are various types of reinforcement listed here. I just wanted to clarify because negative reinforcement can sound weird to people, and they often think of punishment. It is not the same thing. So with reinforcement, we're always trying to increase the likelihood of a behavior. If it's positive reinforcement, we're adding something. And if it's negative reinforcement, we're taking something away, both to increase the behavior. So there can be social positive reinforcement. So this is just excess attention from exhibiting the behavior. Tangible reinforcement, which is getting an object or an item out of it. So I think of, the toddler throwing a tantrum in the grocery store to get a chocolate bar, and then mom, gives in, and then the toddler learns that when I act this way, I get what I want. Some behaviors are just automatically positively reinforcing. A lot of self-soothing behaviors would fall under this category. Then there's social negative reinforcement, which is escaping a situation. So this, I think of a kid acting out in class because they don't want to do work, and then the teacher sends them out of the classroom or sends them home. So they get what they want, which was to not have to do work. And there's also automatic negative reinforcement. So sometimes aversive stimulation, such as some kind of uncomfortable condition, is a motivating operation that makes its termination reinforcing. This one can sometimes be more challenging to think of, but an example would be putting calamine lotion on a poison ivy rash can be negatively reinforced by alleviating the itching. So there are barriers to receiving interventions, arguably for anybody, but especially for individuals with developmental disabilities. So issues that caregivers face when seeking service include wait lists, scheduling challenges, costs, geographic location, so it's much more difficult in rural communities, staffing and availability, the breadth of treatment available in the community, a poor fit or rapport with a service provider once they finally have one, not having a diagnosis or having an incorrect diagnosis, which is important because it dictates the intervention provided, and acceptance of a diagnosis. So sometimes people don't like the diagnosis that they have and therefore don't want to pursue treatment for that particular label. Additionally, once receiving treatment, there can be a lack of communication between the various service providers. Caregivers are left coordinating a whole bunch of appointments at different places on different days, and it can be an excess cognitive load. And then there's finding a mix of therapies that happen simultaneously versus linearly. So by this, I mean receiving, I'm going to receive occupational therapy, and then I'm going to receive therapy, like psychotherapy, and then I'm going to see a behavior therapist versus those professionals coordinating and delivering services together. With intervention, there are some important considerations. Number one being capacity to consent to treatment. So this can be tricky to figure out at times. So capacity, an individual is said to have capacity if they are able to understand the nature of the proposed intervention, as well as the anticipated effects and outcomes of going through with this intervention, and as well as understanding the consequences of not receiving the intervention and knowing what alternative treatments are. Capacity is not static, so it's something that has to be looked at again and again, and it can vary according to the supports provided to the individual. So my sort of go-to is that I want to include the individual in the process as much as possible. It's also important to think about developmentally appropriate privacy and confidentiality. So even if I'm working with an adult client, if they have a disability, they sometimes encounter that parents or staff members are very interested and want to know what we're talking about in therapy, and it's not necessarily any of their business or relevant for them to know. So it's important to negotiate with everybody involved, how much you're going to disclose, and the client has to be okay with this. The goals of intervention are to prevent and or minimize impairment by providing external supports or adaptations. This can look like establishing a behavior support plan, parent-implemented interventions, caregiver support, social skills training, visual supports, or adapted psychotherapy, such as CBT or DBT. So briefly, I'd just like to highlight cognitive behavior therapy. CBT is based on the idea that thoughts, feelings, and behaviors are interrelated, and if we can change one of these things, we will see changes in the others. It's designed to treat emotional distress, so things like feelings of anger, anxiety, or sadness, by addressing maladaptive thought or behavior patterns and focusing on building adaptive coping skills. So there are many modifications we can make to the therapeutic process to better accommodate individuals with disabilities. We can change or adapt the language that we're using to their ability level. This can be really challenging until you get used to working with the population. You spend a lot of time in school obtaining your education to work in the profession you want to work in. You don't realize that you're talking at a very high level, and you have to be able to modify that. Sometimes we'll change the frequency of sessions, so they may happen more frequently. So maybe I'd see a typically functioning adult once every 2 weeks for therapy, but perhaps I would see someone with a disability every week instead. Sessions are often shorter due to limited attention span. So instead of the traditional 1 hour session, I usually truncate it to 30 minutes. Therapy may last a lot longer than it would with a typically functioning individual. This allows for repetition, generalization of skills outside of the session, and having more time to terminate therapy when it's ready to end. It's also helpful to use a structured or directive approach when you're communicating with the individuals. You can communicate with collateral individuals with the client's permission, and you can gather and share information with your care team. And then you can modify your intervention by discussing one issue at a time, breaking things down into smaller pieces to ensure that the individual understands, and asking them to reflect the material back to you to gauge their level of understanding. And repetition, repetition, repetition. It's very important. It's also very important that we are supportive. So providing acknowledgement and praise for even small improvements, and being flexible. So if you're not getting the outcomes you thought you were going to get and there's no progress being made, go back to the drawing board and try something else. Some additional accommodations include including a parent or caregiver to assist with coaching and skills practice outside of the weekly sessions, using reinforcement and motivating factors to encourage participation in therapy, using concrete examples to teach therapeutic tools and skills. Again, tailoring strategies to the developmental level, and trying to incorporate skill building and lessons into developmentally appropriate regular activities and routines. So in terms of team-based care, this has evolved in response to the increasing complexities of patient care, with each discipline contributing particular skills and knowledge for the benefit of the patient. And the aim is to provide the patient or client with the best care possible. So we have people with distinct training working together for one common purpose. And an interprofessional approach is said to look like 1 + 1 = 3. So the whole is greater than the sum of its parts, basically. So some principles of team-based healthcare include having a shared culture, common goals, clear roles, effective communication, mutual trust and respect for everybody on your team, recognition of each team member's contribution to the process, and having measurable processes and outcomes. Something that I've become more interested in the last few years as I've been on many teams is what contributes to a successful team, because I've been on excellent ones and I've been on less excellent ones. So some positive features include having respect for different values and ethical positions held by various team members, discussing the role of each team member. This is important because a lot of professions share some roles, or that we see some role overlap. But there are also some subtle distinctions that make individuals unique in their role. It's important to have a framework for decision making on a team. And something I've read is that a team that can air disagreements has a fighting chance of resolving them. And I wholeheartedly agree with that. So while each profession has its own code of ethics or practice guidelines, as we're seeing a transformation in healthcare service delivery, there's arisen a need to identify core competencies that spans across professions and guide us when we're working together on teams. So this is from the Interprofessional Education Collaborative Expert Panel, and it's discussing core competencies for collaborative practice. I'm not going to review them. I just wanted to point out that they exist. And finally, before moving into discussion, I just wanted to highlight one of my current teams, which is Queen's Developmental Disabilities Consulting Program. So this program is a specialized interprofessional service and teaching program concerned with the complex health and mental health needs of children and adults with developmental disabilities and autism spectrum disorder. We provide services to individuals and their care providers across Southeastern Ontario, and services include interprofessional collaborative client-centered care, clinical consultation, assessment and intervention, advocacy and training for caregivers and agencies, and multidisciplinary research and clinical teaching opportunities. And our team is comprised of psychiatry, psychology, and occupational therapy. So that is it for me. I'm going to stop sharing my screen so I can see some faces, but please feel free to share any comments or questions.
Thank you so much, Kelsey. While we wait for our participants to maybe type their questions into the chat or to formulate some questions,
I think
I
Brittany
can
might be
send.
talking, but is muted.
Can you hear me? Can you hear me? Oh, okay.
Okay, technology fail. Okay, now it's working,
Kelsey, can you hear me now?
I think.
No. Okay. Oh no. It seems like everyone else can hear me.
I muted and unmuted and now it works. So
Okay, awesome. That's great. I just wanted to say thank you again, Kelsey, for that informative talk today. While we wait for the participants to maybe formulate some questions or to input their questions into the chat, I can put in the feedback form for tonight's event and for the ICHP in general and the ICHP email in case any of our participants require it. And I suppose while we wait, I can also share some thoughts. I actually had the privilege of working as a part of Queen's DDCP during my placement, which is where I met Kelsey. And through my time at DDCP, I've come to share the same feelings that I believe aspiring healthcare students need to learn more about dual diagnosis and just need to be more equipped with tools to work with these individuals to further support them. One thing that really stuck out to me in terms of how to work with these individuals is CAMH's guide it's sort of a 4-step decision-making guide where because of concepts like diagnostic overshadowing and concepts like cloak of competency, it makes our job all the more important to ensure that we really get at the root causes of certain behaviors. So if I remember correctly, CAMH's 4-step guide is like, first you wanna look at the physical aspects. Are there any sort of behaviors we should be on the lookout that are due to physical aspects? If not, the second step is to look at the support system of that individual or the lack thereof. The third step is to look at the emotional aspect. And the fourth step is finally to look at whether or not there is a psychiatric disorder present. And when I learned about that, for me, it really opened my eyes and helped me realize that there's a lot of layers here that need to be unpacked, especially for individuals with dual diagnosis. So I just wanted to share that with everyone.
thank you, Brittany. I would also say it's one thing to, look at guidelines and attend the presentations, but I really encourage anyone that has the opportunity to work with individuals with developmental disabilities to give it a try, even if it's new and scary. It's very rewarding. It's a lot of fun. You have to be creative and flexible. Nothing ever goes according to plan, and you have to think on your feet. It will challenge your professional skills. And I think that's how we know that we have those skills. It's one thing to do it when everything works perfectly, but can you adapt it in the moment when you need to?
I have a question. I'm just curious about, I guess, I've been doing some research sort of in the field of intellectual disability in the emergency department, and it's my understanding that there's been a lot of negative experiences of people who are coming for sort of in a mental health crisis, and then having, I guess, like a lot of misdiagnosis is what it is. It's either somebody coming in with a mental health crisis, but then the physician assuming that it has something to do with their intellectual disability, or sort of vice versa, when somebody's coming in with a physical issue, and then somebody's thinking it's more of a psychological issue. So I guess I was wondering if you could speak to that a little bit.
That is bang on. It happens quite often. In terms of mental health emergencies, I have clients frequently that will end up in the ER, because they're threatening to harm themselves, they're feeling suicidal, but they also have an intellectual disability, and it's often not taken seriously. And if it is, they can be admitted onto an inpatient psychiatric unit. But then the problem arises that most inpatient psychiatric units are not equipped to work with disability. So all the other patients on the unit, have programs and groups that they can attend during their stay. And the individuals with disabilities are not that they're not allowed to attend, but aren't really given the opportunity to attend programming because it's assumed that they just can't, and that it's above their skill level. And it may be, but I think that there needs to be programs available, or you could at least give it a try, because just being around other people and socializing could be beneficial. And then with physical health, it can be really challenging with nonverbal individuals. Often there can be something physically wrong, but we have no idea what it is. So it could be, that they have a UTI and they're really uncomfortable, but they're telling us that by like hitting themselves in the head or something, and we don't think to connect the two. And it varies from physician to physician as well. Some have a good understanding, and others may not have received training on the matter. I'm not sure if I have answered or spoken to that adequately, but it is a very prominent issue.
I see a couple of questions in the chat. There's a question that's asking, is it possible that overprotectiveness from parents can impede child's academic and adaptive functioning? For instance, the parents still treat their 13-year-olds as young children and prevent her from being independent.
Absolutely. So this would be called infantilization. So sort of babying, your child with a disability, and treating them, as if they're a 5-year-old when they're a teenager. And it can be really challenging, I imagine, as a parent when, maybe they are 13 and their developmental is like that of a 7-year-old. And it's, where is that sweet spot? But I think most service providers have the goal of fostering and increasing independence as much as possible. These can be really difficult conversations to have with parents when you're pointing out that they may be impeding their progress in areas. So it's to be done delicately. It's also good to do after an assessment when you have sort of evidence of what they're capable of when they're working alone with you, and versus what they do with their parents. And I'm thinking mostly of social skills and that sort of thing, but even with academic skills, they may kind of provide over assistance in completion of homework, or talk on behalf of them when they would be capable of responding to questions on their own. So absolutely happens all the time. It's very frustrating, but it's a very delicate conversation.
I see another question here from Kathleen. Do you have any advice on best ways to practice language modification? I feel like this can be quite challenging, and was hoping you can have some tips and tricks to practice.
That's tricky. It's just a second nature to me now. I've shared with friends that are also PhD students or have PhDs. I feel like I speak very informally now, just because I've gotten used to doing that in my work. I would, ask if you have any friends with children or nieces or nephews, or have the opportunity to interact with young children, and think about how you would interact with them. That's not to say that we are to treat like an adult with a disability like a child, but their ability to understand language could be like that of like a 5-year-old. And I'm trying to think, I'm going to look through my resource folder as well, and I may email it to Brittany if I find anything, if she wants to send that out.
Definitely.
Yeah, it comes with practice, and you can ensure or try to understand if you're doing this appropriately with the client in question by asking them to repeat back to you what you've been talking about, and then you can gauge their level of understanding. And if it's not there, then you need to make it simpler. Also try to keep your phrases sort of short and sweet, as few words as possible. It's also very helpful to accompany, your short phrases with a visual cue. So, having pictures of things. So there's kind of two levels of understanding available. And repetition is also helpful at times.
I'm not sure if there are any more questions. Maybe I will start with a little close off, and in the meantime, if there are any anyone, please feel free to interrupt me. But at this time, on behalf of K-Health, I would like to extend a warm thank you to you, Kelsey, and to all of our speakers this year, and to all the participants as well. These events would not have been possible without your support and your feedback. In the future, K-Health will continue to work towards providing you with interesting events and programs, so please continue to support our initiatives. This talk will be recorded and will be uploaded onto our website and onto our Facebook event page, so please be on the lookout for that. And I think that's all. Thank you all so much for joining tonight, and thank you again, Kelsey.
Thank you for having me, and everybody for joining.
Have a good night, everyone.
Bye.